I'm so very glad to be here and to be part of this new series on thinking about contemporary issues. And as we were thinking about this program, we couldn't think about anything that was more pressing than the issue of homelessness. When we look around the area that we work and live in, when we think about the individuals who are in our community, when we think about some of the major challenges, clearly thinking about individuals who are homeless is an incredibly important issue. So it's very important to us and very happy for us to have a recognized leader, Dr. Jim O'Connell, to be our guest. Dr. O'Connell has a very impressive background, and many of you may know him already. Jim finished medical school in the early 80s and became the founding director of the founding physician at Healthcare for the Homeless. Jim now serves as the president of the Boston Healthcare for the Homeless, which has a very extensive program, and we'll talk more about that particular initiative in a little bit. The primary piece of that, of course, being the Barbara McGinnis house, which is across the street from our school with the 104 respite bed facility. In addition to all of the impressive things that have been developed in this project, Jim has also done a number of very impressive things himself, including designing the first electronic medical record program for individuals who are homeless, for establishing the Homeless Vulnerability Index, as well as serving as the first national program director of the Homeless Families Director Program, which was funded by Robert Wood Johnson. In addition to that, Jim has had articles that have been printed in a number of professional magazines, and he has received a considerable number of honors for the work that he has done. So it's very wonderful for us to have Jim here, and as the Charlie Rose of this conversation today, we're just going to kick this off. Jim, I think maybe the place we want to start is with the closure of the bridge. So when the bridge closed, it caused some problems. But given that we have some new people in our audience, it might be a good thing if we bring them up to speed about what we're talking about of the closure of the bridge.
Be happy to. And first of all, can you hear me okay? Is that?
Yeah.
It's an honor to be here. I'm exquisitely uncomfortable sitting up here in front of all of you, as you can see. But I'm actually thrilled to be here because the School of Public Health here has really, and many of you in the audience that I can see who have been our friends and partners for 30 years, has been one of the really dynamic forces in our lives. So it's, let me start by saying thank you for all you do because it's really special. The bridge was was an interesting, I think, city dilemma. So for those of you who don't know, back in the early 1980s when homelessness was sort of on the rise, and there were lots of reasons people would surmise about why, but we were in the city of Boston as well as in other urban cities feeling the pressure primarily in emergency rooms. Homeless people showing up in emergency rooms with no, they were just coming in sick with no care that was either continuous or preventive. And Pine Street Inn at the time was, it still is, the largest and the oldest shelter in New England. And they pressured the mayor, who was Mayor Flynn back then, to come up with some way to take the burden off, so to come up with a shelter for the city. The mayor looked around for a place that he could place the shelter, and there was really no neighborhood that he could really convince to take a 400 or 500 bed shelter, pretty understandably. So he did this really interesting, and as I think in retrospect, kind of brilliant idea of the island, which is Long Island, was the site of the oldest chronic care hospital in the country, run by the Boston Department of Health and Hospitals. It also had been, earlier than that, had been the almshouse for the city of Boston. And so he realized that you could put the shelter in an abandoned building out there that could be relatively easily and quickly renovated. And the price you would pay is you would bus people from here at the hospital, which is Boston City in the old days, right out to the island. And that became the City of Boston's homeless services. I used to work out there in 1985, and I see Jim Green in the audience here, who's the emergency shelter commissioner for the city. And I met Jim working out there in 1986. So I'm going to have to look over to Jim Green a lot today for help on some of the city view on much of this. But what happened is, at first I thought that was a crazy thing to do because it felt like you were exiling people. It felt like you were just getting them out of sight, out of mind, and homeless people just shipped out to an island, bust out there. But then I grew to realize, as we worked more there and saw different programs grow up there, is that without the pressure of a community, the programs could be very creative. Okay, they could, as you got a good idea, you could relatively quickly put that idea into place. And I watched many of the programs, the Long Island Shelter folks, which were run by at the time, the City of Boston Trustees of Health and Hospitals, now the Boston Public Health Commission, did these remarkably wonderful things. There was I remember the very first program for people with AIDS back then, who were still using, and you were trying to get them to get clean and sober so they could get into treatment. And that was very hard to do when you're on the street. So they set up a program where you could still use and still be drinking while you could think about getting clean and sober. And it was a safe place to be. It was called Safe Harbor. And I think it was funded by HUD. It was incredibly creative and was really a leader in the country for how to address that problem. Then there were recovery programs that built up there. The state's first dual diagnosis detox for homeless folks was out there. They even had a very creative farm, which many of you may know of, which was an organic farm which supplied most of the vegetables and greenery for the shelter food. So it was really lots of stuff going on there. The challenge always was that the only way out to the island was over this causeway, which you have to go down the expressway, you get off at Neponset Circle, past Marina Bay, through Squantum, out to a little bridge that goes to Moon Island, then a causeway that goes onto the island itself. And that was the way to get there. And that bridge, the very first night I drove across that bridge, it was in July of 1985, they were repairing the bridge. So the bridge was in constant need of repair. And over the years, it became more and more irreparable without being replaced, but the cost of replacing it was always prohibitive. So this past October 8th, the state inspectors declared the bridge really unsafe for passage. And the mayor, Mayor Walsh, who was the new mayor at the time, so this was a problem that he inherited from the past, had to make a decision about what to do. Was it safe to keep busing people over there or not? And he landed on the side of saying we need to close the island for safety's sake. And so on October 8th, this is coming up almost on a year now, the island was closed and we had about 4 hours to evacuate everybody. And it created what I think, from a public health perspective, was a disaster response for the city, because effectively there were 450 people in the shelter and another 400 or 450 people in all the various programs out there who were homeless and now being brought off the island, dropped right here at the corner of Mass Avenue and Albany Street, and then the city had to come up with plans for what to do with that. And that created for all of us, this is October, just before the winter. As it turns out, it became probably the worst winter we've ever had. And the city came up with some really quick, creative responses, none of which were enough to replace the island. So there was always the pressure on how to go. And we could go into more of that if you want. But that, to paint the issue for all of you, that we basically lost half of the available detox beds for homeless people on that night in 4 hours. Those have never been replaced. We lost 70% of all the treatment beds for women in the city, and those have still have not been replaced. And the city worked very hard to replace the shelter, and you probably all know that Southampton Shelter opened a few months ago, right down the street, and Woodsmullen Shelter, which is a building, the old laundry building to Boston City Hospital, which is right next to our building, is now a 200-bed shelter for women. And so the city's response was to get folks studying. During the winter, of course, they were in the gymnasium, and it looked like there had just been a hurricane. There were cots all over the place, and everybody was sleeping very close together. There were only about 3 stalls in the bathroom for 275 men, and it was a pretty tense and tough winter. And the response by all of the people working the Boston Public Health Commission, the shelters around town, the folks in our program, was really stunning in how they all went together. But it became a true public health problem for the city of Boston.
Jim, the issue caused a lot of problems for a lot of people, and there was a lot of consternation. There was a lot of finger pointing. There were a lot of people who said it should have happened one way, it should have happened another way. But what do you think that bridge closure and the resulting problem says about the way that we treat homeless people, and what does it say about ourselves?
It's a great question. In fairness to the mayor, by the way, about a week or 2 weeks after he closed the bridge, a big steel structure fell on the bridge. So there was no question the bridge needed to be closed.
Yeah.
Okay, so I don't think there's any
So let me
issue.
tell you something first.
Yeah.
You know, so when I used to go over that bridge, which I did often, I used to make a decision, was I going to roll my windows up or roll them down? Because I didn't know if I wanted to be able to get out in a hurry or for the car to be able to float. So I could get out.
The end, we talked about that a long time. Keep the windows closed, so when you go under, you have a little air pocket.
Oh,
so
yeah.
that close up and then you go. So that was easy. But you could look down and see the water, and it was always, if it was a windy night, it was a pretty scary
And what was
ride.
horrible is going over at night when you couldn't see. Bad.
It was really tough, and for the
So what does it
workers
say
out
about
there-
us?
Well, I think that's why I tried to preface this by, at first I thought we were really, that it was taking an almost intrinsic problem and putting it out on an island and saying we're not going to think about it anymore. But then I changed because I think we were able to do, the city and lots of different agencies were able to do really creative, good things, and lots of people recovered on that island and did really well and moved on to housing. So I began to see the island as really has a very important part. And let me tell you also something. There are many people, to get to that island, you have to get on the bus, over here, drive, go out there and sleep in a shelter where men and women were in the same cafeteria, actually shared the same things. You have to share the bus. And so for many women in particular, it was not a viable place to go. And Pine Street Inn, as you know, has a separate building for women, which is now basically the largest women's shelter in the country, believe it or not. It's called the Women's Inn, probably has 150 women sleeping there. And you don't hear much about that, but many women go there because it's the safest place for them to be. Now, for women to get on the bus and go out there, you have to be gregarious and social. And men who want to get on that bus have to also be ready to make, because you have to be organized to get on that bus. And so many people would get out there and feel relieved that they could be away from the city. And I don't know if any of you have ever seen it, but when you're out on the island, it looks down across the harbor down to downtown. It's beautiful. It's actually beautiful real estate. I used to think I couldn't believe the shelter would be there because somebody's going to develop this place very soon. So I came to realize that while some homeless people would hate the thought of going to the island, others cherished it. They found it as a way to get out from downtown, to be away from the craziness of it, and have a chance to sort of step back. So I did come to love the island. I don't know how many of you in the audience have actually worked on the island. I know Jim did, and I think we both had our mixed feelings, but both came to love it. What we didn't quite figure out, and this is where I think the tricky part of your question comes in, I think it was inevitable that bridge was going to have to be closed. I think that citing any of those programs in the city is a several-year process, not an overnight process. So to get a neighborhood to work a community process, to get a neighborhood ready to take a detox unit or to take a recovery program, you really have to amass a really community organizing thing. And that was never done. Now, I don't know who, I don't mean to finger point on that, but that was never done, despite the fact that everybody kept saying at some point the bridge is going to close. So we ended up with the closure of the bridge and no plan, other than a disaster plan, right, which was, so I think that says a lot about, I think the priority in our city planning and our state planning and in our own planning, I don't want to blame anyone in particular on this, was that we didn't appreciate the enormity of the problem and how we needed to really respond to that. I think there's another issue, which I'd love to talk about at some point, and I've been struggling a lot about this, is that I think we're also a victim of, maybe not a victim, but we're in the middle of a whole sea change in how people are approaching homelessness as a social issue and as an ethical issue. And I think for years now, the prevailing attitude has been that shelters were a failed social policy. Shelters just let people linger there. They were not moving from there into housing. Many people had been in Pine Street Inn for 30 or 40 years. And that was not solving any problem. And so for lots of reasons, which you could talk about, most of the government funding now comes toward ending what they call chronic homelessness through housing, which is really laudable and the right thing to do. But in the effort to do that, funding for shelter has become sort of something that is low on the priority. list. Even most of the shelters, around town to what they're doing, and they're doing this incredibly well, is taking people that have been in their lobbies for a long time and now investing in housing and getting them into housing. So with that policy having shifted dramatically over the last decade, the need to shelter 900 people who all of a sudden are now need shelter hit everybody smack in the world. We have no advocacy anymore for shelter. No one's out there saying we need more shelters. And that became as much as, as we looked inside, that was a problem. What do you do with these poor people left out as the winter comes who have no place to go? And it was if you notice, it was a quiet advocacy world. When you look in the newspaper, was there anybody screaming that the detox beds have not been back? Or it was usually only the homeless people themselves that were screaming?
To the mayor's credit, it is important to say he just came into his role as mayor and took the actions that were needed at the time to address the issues and continues to look at that right now. I want to switch gears just a little bit, and I want to come back to the repercussions of the bridge closure. We talk about homeless individuals all the time, and in the School of Public Health, we often talk about it in terms of numbers. We have this many people, we have this proportion, we do this, without clearly understanding who we're talking about. You are an incredibly impressive and wonderful listener. And I'm wondering if you could help put a face on the kinds of things that you have heard from people about what keeps people on the street.
Let me backtrack on that for just one moment, but I will answer it, I promise. I think
because that's your job.
It's my job. That's true. I'm speaking to people that are at the School of Public Health. I think we know so little about homelessness. It's studied so superficially so far. With some extent, that we are screaming for people with creative ideas on how to look at this population. And what we do know is when you parse out the population, there are vast majority of people are homeless for a very brief part of time, and they tend to be one, you could describe them one way. Then there's other people who are literally homeless for 30, 40 years. And they tend to be a subgroup of the homeless that are the most, they have the highest burden of illness, usually co-occurring mental health and substance use problems. And they are the toughest to figure out how to address given the limits of our own systems of care. So when I think of those folks, okay, which are arguably the minority, but still the ones we see most, I've been baffled by, the longer I do this, the more complicated the problem seems to be rather than the more simple. So when we look at, my clinical life, by the way, is taking care of people that primarily live on the streets and don't go into shelter. And just to paint a picture for you, because one of the true blessings of our lives living in a city like Boston and a state like Massachusetts is that most public policy toward homelessness has been incredibly gracious and incredibly creative and incredibly well funded when I look at my friends in other states compared to that. So the mayors of Boston, all three of them that have been there while I've been working, have all assured everyone that there is a place for you to stay tonight. If you're if you're an adult and need a place to come, you can come into a shelter. They will find a place for you. It was a little tricky to that in the winter, this past winter, but if you leave this winter a little bit alone, there's always been that. Which is pretty remarkable. And you don't have to be clean or sober to come into a shelter. You can't use when you're in the shelter, but you don't have to be sober to come in. I have lots of friends who work in other cities like Portland, Oregon, and Seattle, where most of the shelters are dry. So the people living outside are those people who are still struggling with the substance use. But that's not true in Boston. You can go into Pine Street, you go to Long Island. So the people who live outside, okay, have chosen for whatever reasons not to go into the shelter. They could go into the shelter, but they've chosen not to. We used to ask them, why do you choose to live on the streets? And to a person, they get mad at us and say, I'm not choosing to live on the streets, I'm just choosing not to go to a 500-bed shelter with all the rules and regulations. And if you ask people why, the answers are legion, okay? They're the most remarkable one I can remember is that one man, when I was asking, why don't we take you in tonight? And he told me, he said, look, if I go into Pine Street, I can't tell whether the voices I'm hearing are my own or someone else's. When I'm outside, at least I know the voices are my own. So he wouldn't go into that. Other people are just too paranoid to be around a group this size or live by the rules. So there are lots and lots of reasons why people choose sort of independently to not go into the shelter. And then when you look at who are those people, they tend to be the people that have suffered the most severe trauma growing up, who have suffered all the adverse effects of growing up in abject poverty. So what we see, what's numbingly familiar, it's people that were in foster care, people who were in trouble in school because they had ADD that was unrecognized and they became troublemakers. They were into beer when they were 11 and into other stuff by the time they were 14. And so what we're seeing is people 30 years down the line of living through really all the stuff that poverty does to you. And what we're ending up trying to do is figure out how do you now take care of somebody in that spot. And I think that's the challenge that I would throw out to all of us. It's a tough, complex social problem.
One of the things that we sometimes talk about is ending homelessness. And I'm not always clear I know exactly what that means. I don't know if that means that we have plenty of shelters. I don't know if that means that we are placing people into home settings. What does that mean?
The ending homelessness, as I understand, people can jump in on here. Particularly over the last decade in the U.S., there's been a real emphasis to say we let people linger outside in shelters and on the streets for years without getting into housing. And usually they didn't get into housing because am I doing this wrong? Sorry. They didn't get into housing because they weren't taking their medicines or they didn't get sober and they weren't going to the halfway house. And so there was a flipping of that idea to say, if these are the people who we are spending lots of money on the streets and in the shelters, why don't we flip it and have them be top priority for housing? Go into housing and then get the kind of supports they need to get sober or to get on their medications, et cetera. This is called Housing First. You probably have heard this, and there's several versions of Housing First, but it really meant literally taking someone from the streets, saying, here's a key to an apartment, do you want to come in, and take them into the apartment and then provide the services. And that's what they mean by ending homelessness. So when you go from that setting into a housing, you have effectively and literally ended homelessness. Yeah. And I think that has been the real thrust of most federal policy for the last 10 years. You are hearing now about ending chronic veterans homelessness, ending chronic homelessness, ending family homelessness, and that's what they're trying to do. See if they can generate a will on the part of politicians and everybody else to create the housing that can stop this problem.
I understand. I'm just going to look at a technical person, see if there's something that should be doing differently. No? Okay.
Is it coming out?
Just keep on doing what you're
just
doing.
Just keep on doing it.
Yeah, right. Just talking to the mic.
If I talk down.
Right. Yeah, here we go. Right here. It's just you and me. So.
I've been trying to do that all my life.
Yeah, right. Just don't pretend like there are other people out there.
Right.
Jim, let's switch gears again and talk about healthcare for the homeless and the work that you do. Could you tell us about your work and about your organization?
Sure. So the Healthcare for the Homeless program began with a Robert Wood Johnson Foundation grant, as many grants around have come from. And it was a 4-year grant given to cities. There were 19 cities that got these in the year 1985. And the mandate from the foundation was to give these grants to mayors. They weren't given to counties or to states or to individuals, but to mayors. And it's interesting, as I'm sure many of you will see, the problem of homelessness really falls on the mayor's laps in most cities. It's usually they're the ones who feel they're on the front line and they get it. So, and in Boston, one of the real blessings for a program like ours is that the community of stakeholders that was required by the foundation included a lot of really feisty, wonderful advocates and homeless people themselves, including many of you may have remembered Kip Tiernan, who founded Rosie's Place. If you ever saw Kip, she was one of the hardest driving, hard smoking, fedora wearing, real fierce advocates, a really wonderful woman. And the advocates in Boston were really annoyed with the healthcare system or the medical system really for failing to take care of homeless people. So when they had this opportunity to air out what their grievances were, they made it very clear how they wanted to be cared for. I was still a resident, so I had nothing to do with this, but I walked into what I was so surprised at. So for example, they said, and check this out, they decided, and there's a Hail and Door document that they had the mayor sign, Mayor Flynn sign in 1984, which said if they're going to go along with our program, it had to be based on social justice and absolutely not on charity, which I didn't know at the time because I had gotten every friend I knew when I was taking this job, I had lined up to do volunteer work. My friends in dermatology, cardiology, they were all going to do a night every month or something like that. And they said because this was social justice and not charity, by the way, Kip's, I'll never forget the first thing Kip ever told me was, when she was reading me the Riot Act about being a doctor who didn't take such good care of people when I was in the hospital. She said, charity is scraps from the table, justice is a seat at the table, and they wanted a seat at the table. And so we could not use a single volunteer in our program. So when we started out, we had to have full-time people who would provide continuous care. You had to be available to people just like you would expect your own doctors and healthcare teams to be. A total shock to us because we only had like 3 or 4 of us and we didn't have that many. We needed some volunteer help. But that set the tone for what happened. For example, they insisted that homeless people, if this was going to be justice, they insisted that homeless people had to be involved in the planning, implementation, and governance of the program. So like we just had a board meeting this morning, and we have 5 literally homeless people who have been on our board. That's about 1/3 of our board of directors. It used to be we had 3 desks and we used to be about 1/2. And they are the people, they are on our board of governors. They hire and fire us. So it's very different from what I used to at the hospital where we had a different type of board. This is a board that's really community-based and really looks at what you're doing. But that all came out of a mandate that we were given a long time ago. So with that as a background, what they told us we had to do was they were mad at us as doctors and nurses for staying in the hospital and waiting for people to come to us because they said that's too late. If you're trying to survive on the streets and find a bed for the night and your next meal and enough money to have a cup of coffee, you're not going to go to an appointment about your diabetes or your high blood pressure that you can't even feel. So we had to go to them. And the idea was that we needed to go to shelters and soup kitchens, wherever people were, try to set up clinics there where we would be available to people. And then the other thing they said is that we could not be separate from the mainstream, which is an interesting twist. I tell you all this because Boston looks very different. As you can imagine, each city that got these grants had a different approach. So when you hear about healthcare for the homeless programs, unfortunately, when you've seen one, you've seen one. They don't have a common ground. But so what we had to do was stay very much part of the hospital because they felt when the homeless people were so sick, when they needed to go in the hospital, they wanted the same caregivers following them through. That was the concept, or at least being involved in it. So our doctors had to be on the staff at Boston City right from the beginning. And Boston City was incredibly good about helping us set up right within the section of general medicine, as maybe you know, a homeless program. So we were just part and parcel of that. So we could see people out in the shelter on the street. If we needed more, we could see them in the hospital. And the same thing happened at Mass General. They wanted both a public and a private hospital to be involved. So to this day, our program is has 2 clinics based at daily clinics, Monday through Friday, here at Boston Medical Center, although it's now in our building across the street, but we like to think we're still part of the hospital, and at Mass General. And our docs are part of those departments. And then we go out to about 60 or 65 different shelters and soup kitchens and do regular clinics out there. And that's the network. In Boston? In Boston. Our mandate was the city of Boston. And the only times we've Boston is for when Boston families, homeless families are placed in motels like in Waltham or in the South Shore or North Shore, we will follow Boston families to those places. So our mandate is pretty much metropolitan Boston. So what happens with the challenges of an individual who doesn't have a home, who doesn't have a telephone, who no address, that needs to come to a medical appointment? Do individuals have regular medical appointments? Do you catch them as they are available to come? How does that work? It's a great question, and it works. What we've learned to do is depending on which population of homeless people. So for example, our street folks that I take care of, we never do an appointment. We just are open to whenever they want to come in. Because if you set up an appointment, no one ever shows up at that time anyway. For other people who've been housed and are trying to get their lives together, appointments are very important to them. And so we will do appointments for that. So you'll see a mix across the program of how we approach it. In many ways, without thinking about it, it had to be patient-centered. Whether we liked it or not, we had to be patient-centered. If we weren't going to succeed. So one of the things I would share with you, which since you're in the city, is that the city of Boston is a tiny city geographically, but it sits up with big cities that are, like we have colleagues in Houston, where Houston is as big as my home state of Rhode Island, whereas Boston is like this big. So one of the advantages we have is that people are geographically relatively contained. And what was surprising to me when I first started, I thought it was all chaotic. I thought people just were all over the place. But most homeless people have a ritual and a routine and places where they like to, even though they don't have neighborhoods, they have places they will gather. And we learned from early on, as Jim Green could underscore, when the Department of Public Health gave Pine Street Inn the money for an outreach van at nighttime, for example, which was brilliant. This was in 1986, when we realized that we had all these shelter-based clinics, but the people staying outside weren't even coming into them, so we had to get to them. And we had an outbreak of tuberculosis that really emphasized how much we had to get out to them, because those are the people that we had to treat. And Pine Street has had this van going every night from 9 at night till 5 in the morning. The staff are these remarkable people who, many of whom are formerly homeless, many of whom are in recovery. They're people that just are street savvy, never judge anybody, and over time get to know everybody out there. So you were to ask, I don't know what happens to this. I need to hold it, huh? So if you were to ask me now, like we're worried about so-and-so, if we called the van, 90% of the time they'll find them within an hour. So it's not the chaos we once thought.
Yeah.
Within the chaos, there's some ritual and routine. And Boston has the ability to follow people, which is really remarkable. My friends in New York City laugh when I say that, because if you disappear from one borough to another, they have no idea what's happened to you. But that's a relatively rare thing in Boston.
Jim, we've been able to get a kind of an overview of the problem and understand some about your program and about the Barbara McGinnis House. And I want to ask you who Barbara McGinnis is and how that name comes from. But I also want to make certain that people in our audience also have an opportunity to ask questions. So if you have questions, if you'll raise your hand, we'll be happy to acknowledge you and to ask those questions. But while we're waiting for people to ask those, to decide what questions they have, who is Barbara McGinnis and how does the house get that name?
Hello?
Maybe we could share.
So I think it comes in and out, so
Okay,
here it goes.
all right.
Get it for a minute.
We could stand up and do a act. Oh, great. There you go. Yeah, you think it's on.
Is it on?
Yeah, you had to hold it up to your mouth.
Is it on? It's on? You can hear it?
No? Let me try. Hey.
So I'll yell at you. Is
Yeah,
that better?
there you
Okay,
go.
I'll
All
yell
right,
if
there
I
you
yell.
go.
Okay. Barbara McGinnis is one of the most remarkable people who we have ever met. So Barbara was a nurse. She was a nurse who was originally here at Boston City Hospital, but then became a public health nurse for the state of Massachusetts. So she worked for the Department of Public Health, but she was assigned to Pine Street Inn back in the late 60s, if I'm correct, late 60s, early 70s, because of tuberculosis outbreaks there, and she was trying to manage those. But Barbara became kind of the legendary nurse on the streets, and I would dare say that almost everything we do in our program we learned from the nurses' clinic at Pine Street Inn. And the nurses there were all BCH ED nurses who went down and decided to do clinics down there because they thought they could take care of people before they needed to go to the emergency room. They were fabulous. So when I started, the story that I would share with you, just so you can laugh with me a little bit, is I finished my residency in medicine at Mass General in June, and my last rotation was as a senior in charge of the intensive care unit. And for those of you who've been through it, you know, as an intern, your ego is squashed into something about the size of a ping pong ball. But by the time you're a senior resident running the ICU, you think you can do anything, okay? And so I marched into Pine Street Inn the day after I finished the ICU, thinking, you know, I'm the first full-time doctor they've had, and they're going to be thrilled that I'm there. And I ran into this group of nurses sitting around who were really severe, really pretty angry. And Barbara, being the spokesperson, sat me down, and they basically said, look, we've been doing this for the last 15 years without the help of doctors or hospitals, thank you very much. And if you sit down, we will give you your apprenticeship. And what Barbara made me do for the first 2 months that I was there was soak feet. Okay, she took away my stethoscope, wouldn't let me do any, you know, what's your chief complaint, anything like that. And I had to soak feet. And what the nurses did, which was brilliant, was around the waiting room, they had people sitting in the chairs, which were like the old chairs from your classroom with an arm here, and they would soak people's feet. And I can remember thinking, you know, I have clearly chosen the wrong job, among other things, and I don't think they're ever going to believe me, because I was anxious to show them how good I was as a doctor. But what I had to do then was soak feet, and it really is fascinating. What it does is, one, it's comforting. Okay, somebody comes in after you're walking around all day, to sit down and have somebody soak your feet is really comforting. It used to be warm water, and we would put a little betadine in there, which was, now that I've talked to my ID friends, that was probably counterproductive, but that's what we did. And then what it does is it reverses the power structure, so instead of, it puts the person at the head and you at the feet. And in some way that takes away the intimidation for a lot of people. And so the story that I often tell of is Barbara made me do one gentleman's feet particularly because his feet were so swollen that they required 2 buckets, one for each foot. And he was someone I had seen in the emergency room a gazillion times at Mass General. And in our chart, I remember he was labeled a schizophrenia, paranoid type, treatment resistant. Remember, that was right in the chart. And so I soaked his feet for probably a month, maybe 5 weeks, never said anything to me. And one night he looks down at me and he goes, hey, I thought you were supposed to be a doctor. And I said, oh, you know, it was the first person that actually said doctor to me the whole time, okay? So I lit up, and he said, what the hell are you doing soaking feet? And I remember telling him, I don't know, I'm just doing what the nurses tell me to do.
Which is what you should do when the nurses...
But he looked at me and he said, smart man. Go figure. Never said anything to me before that. And it turned out then, a few nights later, he asked me if I could help him sleep, if I could give him something to help him sleep. I remember giving him a little Haldol, which is an antipsychotic, but also not a bad sleep medication. He took it, didn't get that much sleep. He said, Doc, it works a little bit. Can you give me a little more? So I gave him a little more. And actually, that was the beginning of a path where he started taking the medications we had been trying to get him to take for 25 years. He got in a group home, and he stayed in that group home for about 22 years before he died of an unrelated thing. But it was a lesson for me. What Barbara was trying to say is, look, when we're training, the one thing we're not given is time with people. What we are given is a very brief time to get a chief complaint, the whole thing. If I wasn't seeing 4 people every hour when I was doing my clinic at MGH, someone was knocking at the door to see if they could help move things along. And Barbara was trying to point out this took 6 weeks of soaking feet to change what had been a very expensive problem to the system into something that was now costing nothing. And I think that was the real lesson of Barbara. So Barbara went on to she was known by just about everybody. She was refused to ever take any kind of title. She saw herself as a nurse, and that was what she was proud of. Wouldn't supervise anybody, and think she was probably a nightmare to supervise herself, And she really just set the tone for us. She became part of our board of directors. And she was the one that pushed us very hard to do this, what we call a Respite Care program, which is our McGinnis house. And what that was, in 1985, the shelters were so burned by having people come out of the hospital who are way too sick to be in the shelter. And remember, the shelter kicks you out at 7 in the morning. You can't come back till 4 in the afternoon. So if you're just coming out of the hospital with bad back pain, or if you've just had severe diarrhea, all those things become impossible to manage in the shelter setting, and people are then walking outside all day. So they wanted what they called a respite program, which is a place where people coming out of the hospital who didn't have a home to go to could go and have nursing and medical care around the clock while they recovered from their problems. And Barbara pushed us hard to do that. And we were given 25 beds in the corner of the Shattuck shelter back in 1985, in September of 85. And we started doing respite care. There was no rules for respite care. It was whoever didn't fit into the system. And two things happened back there, which I think are pertinent public health issues. Remember, I'd come out of sort of standard training in medicine. I had no public health background. I'm not even sure I understood public health at the time. And one of the first nights I shouldn't say one of the first, but in August of that year, the staff at the shelter asked me to see this man. They brought him in, and this is not the clinical staff. They said, "Hey, doc, this guy just doesn't look right." His name was Jack. Can you see what's going on? And I remember talking to the man. He was skinny, he was drinking too much, smoking too much. But he looked at me and he said, "Doc, I'm fine. I don't know what all the fuss is about." And I took his vital signs, they were normal. I did, all the exam, it was normal. And remember, I'm trying to impress people with how good I am, so I wanted to make the diagnosis, couldn't find anything. So I said to the staff there, I can't see anything. I know he needs to stop drinking, smoking, and he's too skinny. We got to work on nutrition, but I don't see anything acute going on. And so they said, "Okay, doc." And I said, "But if you don't think he's any better, bring him back." And so a couple nights later, they brought him back. And I don't know if you knew, but Pine Street Inn has an old X-ray machine down there. It looks like a cathode ray gun, okay, from the old days, that was there from a previous outbreak of tuberculosis. So we did his X-ray, and it turned out to look like a third world X-ray. It was a complete whiteout of one lung, he had an apical pneumothorax in the other, and just cavitary tuberculosis like you would only see in a third world country. And he was the index case of what turned out to be 62 cases of active pulmonary tuberculosis in the shelter over the next year or so. So all of a sudden, we're in a 700-bed shelter, and and it turned out to be multi-drug resistant tuberculosis. And many of you may know John Bernardo, who's here, and Ed Nardell was there, and they really rallied the troops at the Boston Public Health Public Health Department then, and the State Public Health Department, and the nurses in our program to figure out how to treat these people, all of whom needed 4 medications every day for 18 months to treat. And I can remember all of a sudden realizing I am only as good as the people around me. There was no way you could be a doctor taking care of this alone. And so our respite program, which originally we didn't know what it was going to be, all of a sudden became kind of a TB recovery program, except that then 2 months later we saw our first case of AIDS in the shelter. We had any cases of AIDS at that time. So within another month, we had literally dozens of cases of people who had been diagnosed with AIDS in the shelter, all of whom died within 4 to 6 months. And so we were all of a sudden awash in these awful epidemics with a skeletal staff working with the nurses and the public health departments and the outreach workers. And I think it taught us a lesson back in 1985 of how to come together as a community to really share in the care of this population. And it was, in retrospect, even though it was a nightmare to do. By the way, that multi-drug resistant pulmonary tuberculosis, no one in that group was immunocompromised. That was strictly drinkers. No one had AIDS. So it was a pre-AIDS multi-drug resistant. And the way the city turned out to take care of that was the way that actually Paul Farmer and Jim Kim used to then go take care of TB in Peru and in Rwanda. So we learned then that sometimes care of inner city folks here in the U.S. and in the main world is much more akin to third world medicine than it is to first world medicine.
Jim, again, I'm going to ask to see if there are questions that might, oh yes, a question here.
Hi, my name is Greg, and I was just wondering just thinking about the last decade, I was wondering how the homeless population has changed in Boston, and specifically I'm thinking of veterans from recent wars in Iraq and Afghanistan, and also financial crisis. So, and what sort of changes have you had to make to caring for for homeless folks in that vein?
It's a great question. I would say this is where I might punt to someone like the Emergency Shelter Commission. But what has happened, I would say in the broad strokes, right? So what has been done for years by the city of Boston, actually going back, Jim, help me, 32 years or something like that. How long has the census been going on? For a long time. 35 years. So unlike most cities, Boston has had an annual one night, usually during a cold month of December, census of what's going on. And then that's how we've learned most about what we know. And over time, what you can see is that number, the total number, just goes slowly and inexorably up. And if I'm not mistaken, even in times of economic crisis or times of largesse, the number just seems to march through it, okay, which surprised me. What has changed, though, is who, so the number keeps going up, but within that number, the number of families, for example, which used to be maybe a quarter of it, is now a half, and maybe even a little bit more than a half. The number of single adults sort of has stayed stubbornly about the same. The street population has gone up and down. So we've learned a lot about small trends, but I think if I were to step back on that and say now that I think family homelessness has been the most shocking one of all and been on the rise most. I think we've seen a relatively steady adult population, which I think the city has been doing a fabulous job of keeping to that level by having enough housing programs, creative housing programs, to get people out, but the number coming in is kind of rapidly backfilling. So that is a challenge. But then there's a lot of concern now that youth, runaway youth and adolescence is becoming a big concern. We haven't, though, if we step back, we haven't seen the average age of the whole population change that much. We have in our own program, our Healthcare for the Homeless program, we have an electronic record. So when anybody's seen in our 2 hospital sites or our 65 outreach sites or in our McGinnis house, is all in the same record. So we can sort of look at 12,000 people we saw last year and give you the demographics. And interestingly, that has not changed much over time. So interesting dilemma. Veterans is the question you ask, and I think, and I would love to see, we don't have great data yet, although it's coming. We saw an awful lot of homelessness in Vietnam and Korean War veterans, but we have not seen that much among the Iraq and Afghanistan war veterans as yet. So it may be that there's a delay, just as it was with Vietnam, or hopefully it means that the services that people have available to them when they come back are so much better now. So we're hoping that the latter is true.
Jim, let me switch gears a sec and ask you a personal question as we're waiting for the next person who wants to speak from the audience. So, what have you learned? How has this impacted you? This has been your career.
I dodged that question. So, you know what I think I've learned? I've learned that one, that you have to be in it for the long haul, and that you can't take, there's brief successes and lots of grand failures, but the trajectory for what we're doing is slowly and inexorably getting better, but not getting better quickly. So I think if you're looking for quick successes, this is the wrong field to be in. I think what I've also learned, especially with all we do, for example, in our program now, our team does an awful lot of house calls to people that were on the streets for 20 years, now in housing, and we'll visit them at home. So in fact, half of our life is now doing that. And what we've learned is housing is absolutely, absolutely critical to whatever the success is going to be. But it isn't the complete answer. And that what we're dealing with is a problem that I think now is a problem of, all the social determinants of poverty. And unless you're going to address those problems, you're probably not going to solve the main problem. You can shift it around a little bit, but you don't really solve the problem. And I think that's what we're learning as we take care of these folks in their homes now. The problems or the furies that drove them to the streets in the first place don't go away just because you're now in a home. And in fact, they manifest themselves in different ways. And they need as much care and service once they're in homes as they were when they're on the streets. And I worry a lot that while we will do creative housing, I think, really well, whether we have the political will to sustain the services, the money for the services that they need is really going to be an issue. So I worry, that's where I currently am now, saying I think we're on the right path, but will anyone really sustain those services?
Jim, in the last couple of minutes that we have for this conversation, what do we do right and what are we doing wrong? And I realize that's an hour-long question.
I think what we're doing right is I think we've learned as a community, meaning Boston, we've learned, I think, that we can organize really good continuous medical care for folks, particularly those who have, by the way, the leading cause of death among our street folks is cancer. Okay, and so when you think of the medical issues attended to people that are living on the streets, they're astonishingly complex and require all the specialists, all the hospitals, and all the rehab kind of facilities you can. So it's a citywide thing. I think we've learned how to do that relatively well. We're getting way better at the mental health services. And I think as I look on the audience and some of the people here where you are the experts, I think we are truly challenged by the substance use issues. And most of the, trying to find creative treatments and solutions and long-term care for people that have struggled with these substance use issues has been one of our real failures at our level. So I look toward that. I think what this city has done better than any city I've ever seen, and I've been in a lot now looking at homeless services, is that the collective will by hospitals, community health centers, outreach programs, shelters, their ability to work together to solve the problem and take care of people has been unique and marvelous.
So last question. In our midst, we have students who are working on a project and so this is good idea, bad idea. And you have to tell me what you think it is. We have students who are working on a project looking at mobile showers in buses. So they want to provide showers for individuals who are homeless, and they want to do this in a bus format and be able to move that bus around to a number of different places. Good idea, bad idea?
Good idea.
Good idea.
Okay.
Jim,
yes.
I want to thank you so you have given our students something that they need to think about. One more question.
I was just afraid they might be sitting there.
Well, they may be sitting here. Jim, you've given us a lot to think about. This is an incredibly important conversation for us to have, so much more that we should be thinking about, and I want to thank you for being our guest today.
It's been my pleasure. Thank you very much.